Questions to the Minister for Health. I call Ciara Ferguson.
Thank you, Mr. Speaker. Question number 1.
Minister.
I thank the member for her question. My department has taken a number of steps to improve patient flow at the Alton Area Hospital. An enhanced minor injury unit was opened in March of this year. It is a phone-first led service. It operates from 8 o'clock in the morning to 9 o'clock at night, 7 days a week. And it's my expectation this unit will see some 20,000 minor injury patients per year, thus 20,000 people avoiding the need to attend the emergency department. My department has also commissioned an enhancement to the Alton ambulatory care unit, operating from 9 a.m. to 9 p.m. every day, 7 days a week, expected to provide almost 20,000 bookable appointments a year. A consultant-led respiratory hub is also available, with clinics operating 2.5 days a week, offering capacity for 1,200 patients each year, as well as providing 7-day respiratory consultation cover for the emergency department and inpatients referral. Western Health and Social Care Trust has established a control room in the hospital to proactively manage the flow of patients through the hospital site and into community services. And a discharge coordination team is promoting earlier discharges and improved weekend discharge rates for patients who have been assessed as medically fit. In addition, the Trust is engaged with GP practices to embed direct referral pathways from primary care into the hospital at home service. Work between the Trust and care homes is also helping to avoid admissions for residents, with plans in place to manage agreed conditions by care home providers, as well as redesigning 7 general residential beds to increase capacity for patients with dementia. The Trust will open a further 11 beds for dementia patients and 8 general nursing beds to help improve flow and discharge from Alton-le-Galvin.
Ciara Ferguson.
Thank you, Minister, for the update and the range of measures. Unfortunately, at this moment in time, things aren't improving, despite the fact that we have the minor injuries unit, etc., as you've mentioned, and despite the fact on a weekly basis there is an urgent escalation where people are removed from their beds onto corridors. Do you believe that additional work needs to be done regarding any medical gaps regarding specialisms and staff to actually reduce the number of people? 29% of people are with more than 12 hours in A&E in Alton-le-Galvin.
Well, I thank the member for the supplementary, and what I would say to her is what we're trying to do is remove the second assessment. So a lot of people end up in a hospital because they start off with their GP, where they are assessed, and then they're sent to the emergency department of an acute hospital where they are assessed a second time. I think that the future is to do away, wherever possible, with the second assessment and be able to, for the GP to be able to refer the patient directly to a specialist service within the hospital. And you will see that some hospitals, as well as having emergency departments and minor injuries unit, now have urgent care departments. And that's what I'm talking about, where you can be referred by a GP directly to an urgent care department. And the kind of theory behind that is that you do have more specialists. And indeed, the future of healthcare and the past of healthcare is a development towards fewer generalists and many, many more specialists. And that is the future, that is the direction of travel.
For his answers, I'd like to commend the heroic efforts of our staff in the emergency department at Alton-le-Galvin. Could the Minister provide us with an update on the Western Trust business case for an enhanced emergency department at Alton-le-Galvin?
Minister.
Well, I thank the member for his question. I visited Alton-le-Galvin a few weeks ago, and we looked at some of the new facilities that are in place there. And I was updated on the fact that there is a plan for a new emergency department. I would have to write to the member if he's looking for exact details in terms of where that outline business case is and what the timeline is for completion.
Danny Donnelly.
Thank you, Mr. Speaker, and thanks to the Minister for his answers so far. The Minister will be well aware of overcrowding within our A&Es across Northern Ireland, where including to increase pressures within the department, and ambulances being stacked up outside the department for up to 12 hours quite regularly. I'd like to ask the Minister what work his department is undertaking to reduce average waiting times across our A&E departments.
Well, I thank the member, and to address the ambulance handover time question, which is a critical one. My department has taken a number of steps to improve waiting times at emergency departments, and reducing those handover delays has been a key priority because the impact this has on the ambulance services capacity to respond to calls in the community, particularly Category 1, Category 2 emergency calls. So a regional process has been issued by my department to all the geographic trusts for the release of ambulances from outside EDs when the ambulance service has an outstanding Category 1 or Category 2 call. Trusts have been working with the ambulance service to introduce new care pathways for patients, to provide alternatives to conveying all patients to an ED. What I would also say to the member is it's about the flow, as the member will be aware. And when I started in the department, one of the cost savings that was put to me, which I could not countenance, was cutting a very significant number of hours of domiciliary care. Because if we do that, then even more patients who are ready for discharge will be stuck in a bed, particularly in an acute hospital. And if those beds are not vacant, then the people in the ED department trying to get into those beds are stuck in ED, and therefore the people in the ambulances can't get into ED. So it's all about the flow, and I would assure the member that we are very well focused on that in the department.
Steve Egan.
Thank you very much indeed, Minister, and thank you very much indeed for your answers so far. The Minister will be aware that the sooner the person can be triaged, it's often better for the patient. Can the Minister provide an update on the work to introduce a telephone triage service locally, please?
Minister.
I thank the member. Well, one of the strategic priorities of the Urgent Emergency Care Review, which was published 2 years ago, was the introduction of local and ultimately regional phone-first services, which would be akin to the 111 telephone services that operate in other parts of the United Kingdom. Local phone-first services are now available in all trust areas. They provide initial advice and triage for those people who are considering attending urgent care services. My department is also exploring the possibility of introducing a regional HSC 111 telephone triage service, which will bring these local services under one easy-to-remember telephone number, subject, of course, to business case development and funding availability. Officials have been engaging with counterparts in England and in Scotland to get a better understanding of how their services currently operate, including the introduction of a mental health hub as part of any new service. That hub, if introduced, would provide mental health assessment and support, including signposting callers to other relevant mental health services.
Neil McAllister. Minister.
I thank the member, and I fully recognise the current situation is unsustainable, and I am determined to see urgent improvements in this area. I'm aware there's unfortunately a significant number of families on waiting lists to access support services, and an increasing number of children with disability on the edge of care. I'm also aware that regionally the limited availability of residential care for children with disability has resulted in a decimated residential short-break service, with a number of residential short-break units being repurposed to provide longer-term care to children with disability. A Children with Disability Summit was convened by my officials last month to consider potential options in respect of improving access. The summit was also attended by senior representatives from each of the 5 geographic trusts and senior representatives from RQIA. It was agreed at the meeting that each trust would develop a proposed Children with a Disability short-term action plan, which they will submit to my department for active consideration in terms of suggestions and estimated costings regarding what is needed to imminently attempt to alleviate some of the significant pressures experienced with children's access to overnight short breaks. I want to fully acknowledge that in the very near future there will also need to be active consideration given to the medium and the long-term plans that each trust will need to consider, and that's in terms of fully addressing the long-standing issues that have existed for children with a disability service. It's important to recognise that overnight residential short breaks are only a part of the continuum of services needed for children with disabilities, and the opportunities to expand support services that can be provided in the community are also being actively considered.
Ms McAllister.
I thank the Minister for his answer, and I appreciate that there is work ongoing. However, the Minister acknowledged in the debate last week about the documentary I Am Not OK. These families and many others will want to know the answer to the question is when will we see an increase in the provision for respite and also an increase in the provision for more long-term residential, because unfortunately it's now arriving at that situation.
Minister.
Well, I think there are two issues that we need to address, and one is the physical infrastructure, the houses, the residential places that we need, because we don't have enough, and I know Professor Ray Jones has some thoughts about how we should reconfigure. But then there is also the appropriately trained staff, because even if we had the money, even if we had the physical infrastructure, do we have the staff to undertake a major increase in provision? Well, the answer to that, I'm afraid, is no, not in the immediate term. There will have to be training, there'll have to be recruitment, and also we're concerned, as we are with all areas of the workforce, about the retention of staff. So can I give the member an answer to that? I'm afraid I cannot give you a timeline. What I can say to the member is this week, and hopefully as early as tomorrow, I will be presented with some proposals from my officials who are working tirelessly on this issue. And if it is as early as tomorrow, then hopefully that is something we might be able to discuss at this week's meeting of the Health Committee. And I would welcome that very much.
Cara Hunter.
Thank you, Mr. Speaker, and I'd like to thank the Minister for his answers so far. The SDLP recently met with the families in the hard-hitting documentary about their lives and how lack of respite services has impacted them. They have referenced facilities that have capacity yet are not fully used. I was going to ask you, Minister, is money the simple issue here, but you did allude to staffing issues. Can you just talk us through a little more about that, and where do we go from here?
Minister.
Well, I thank the member for her question. Actually, when the Professor Bengoa was here last week, in the morning we visited a social care, a residential site in North Belfast, where the point was made to us that there were 5 beds in terms of the capacity of this unit, but only 2 were being funded by the Belfast Trust. It would be lovely to say we could find the money to say the Trust will now fund all 5, but the point that was made was even if that money was available, the staff are not available. So that then becomes a workforce challenge on top of the financial challenge. And solving that, either of those, is not something that can be done in the short term. So I want to be realistic, but I also want to be optimistic, and I want to give a little bit of hope here and say, not least because of that devastating but brilliant documentary, I Am Not Okay. It is very much on the radar of the department, and I'm determined to do something about it.
Alan Crawford.
Speaker, and can I thank the Minister for his answers thus far? Minister, the recent BBC Spotlight programme was incredibly effective and impactful in driving home the particular challenges and pressure some of our families are facing. Can the Minister commit to leaving no stone unturned in finding a resolution, and does he agree that it will be essential for his department to continue to work with key stakeholders, including families and even new independent voices such as his recently appointed autism reviewer? Thank you, Mr. Speaker.
Minister.
And I thank the member for his comments there. And yes, I agree with everything that he has said. It is a very difficult challenge. It's not one that lends itself easily to short-term fixes. But as I say, I hope this week and potentially tomorrow that we will start the process by looking at a number of options. I'm very pleased to see Emma Cubitt in place with return as the autism advisor. I think she's got off to a great start. I heard her on the radio not long after she was appointed, and she is clearly determined to be independent, which is exactly what she should be, holding people's feet to the fire, including the department and including mine.
Alan Killian.
Please.
Minister.
Thank the member. During construction of the new maternity hospital at the Royal Victoria, as part of routine monitoring, the contractor reported levels of Pseudomonas aeruginosa, PSA, within the domestic water systems. Action was taken to remediate this. The contractor continued to test the water and provided a set of samples immediately prior to handover. The results of these samples were reviewed and they did meet contractual obligations. The building was then handed over in March of this year, and following that, the Trust put the water systems within the building into operational mode and ran a period of steady state. And during that period, the Trust took samplings from all the water outlets within the building. PSA, I'm afraid, was detected in a significant number of those outlets. This current issue involves the detection of PSA within the domestic water systems. The Trust want to provide assurance to members of the public that it takes steps to prevent Pseudomonas colonising in their plumbing network to protect the vulnerable patients in their care, and that includes regularly testing the water system. The Trust is currently commissioning an independent review of the water systems at the maternity hospital. It will be undertaken by leading industry experts. It will inform next steps for the Trust under the relevant design and construction contracts. In tandem with that independent review and subject to its final outcome, the Trust is developing remediation options for the water systems. Remediation works could significantly impact on timescales for occupation of the building. Belfast Trust staff continue to provide excellent care to women and babies in the Royal Jubilee Maternity Hospital, and service delivery, I am told, has not been impacted as a result of the delay, but obviously mothers and families are being denied access to the new maternity hospital.
Ms. Cullinan.
First response, prior to the latest announcement, I had enough freedom of information in to ask what the cost of this delay was. I was told by the Belfast Trust it was commercially sensitive. Now, given the vast sums of public money, can the Minister confirm or even commit to bringing back to HMLA the total cost of this delay and the build up until now? Because the answer I was given is completely unacceptable to a democratically elected MLA, and it lacks complete transparency.
Minister.
Well, I acknowledge what the member has to say. I think the only potential confidentiality would be with regard to who was responsible for PSA in the water systems in the maternity hospital. And I know there are ongoing discussions. The member may be aware that previously there was an issue with the water systems in the critical care building on the Royal Victoria site, although I am assured that was of a different origin and a different set of circumstances, which did lead to a financial settlement with the contractor, as I understand it. But the circumstances here are very different. But I think openness and transparency, particularly to MLAs, is what is required, allowing for the fact there may be some commercial sensitivity along the way.
Dan Dodds.
And thank you to the Minister. We know that the cost of the new hospital has more than doubled since the initial business case. We also know from questioning at the Health Committee that Pseudomonas in acceptable levels was present in the water system at handover. Could the Minister tell us what role his department had in the handover, and if the Minister has confidence in the Trust with the new capital projects?
I thank the member. I do stand to be corrected, but I don't believe that the department had a specific role in terms of the handover, in that this was a building that was commissioned by the Belfast Trust, and it was a commercial relationship with a contractor. I think where I have a difficulty is in a broader sense, which is that the contractor ran some tests which were acceptable in terms of how these contracts are managed. But actually, those tests were not replicating how that water system would operate once the hospital had been commissioned and was fully operational. And when the Trust did that, that's when we discovered that the levels of PSA were not acceptable, and the problem has arisen. And it is a very serious problem, and it may take a very long time to fix the problem. And it is a hospital, as a member will know, that has been subject to delay after delay for year after year after year. And the consequence is that the cost of building the hospital is now eye-watering. And I have to say, when I first saw it written down on a piece of paper, I thought there'd been a typographical error. It is phenomenally expensive. And having to spend the money to fix the PSA issue, particularly if the costs fall to the Trust, is going to put even more pressure on an increasingly pressurised budget.
McNulty.
to the Minister for his answers thus far. Minister, what reassurance can you give the midwives at Daisy Hill Hospital's maternity unit who, because of recent actions and inactions by the Trust, are very concerned that his department and the Trust are systematically dismantling maternity services at our hospital in Uri City?
Minister, answer that as you may. It doesn't relate to
Well, as
RVH.
the Speaker suggests, your question has very, very little relevance to the question as posed by Mr Coolan. What I would say to you, gently, is that there were some workforce issues with midwives recently in the Southern Trust, and that was dealt with as best as the Trust could possibly handle it. And I am not aware of any plans to dismantle maternity services at the Daisy Hill Hospital.
Egan.
Can I ask how your department are monitoring the current risks within the domestic water systems across all the Trust areas?
I thank the member, and on foot of the Pseudomonas issue that has arisen in the maternity hospital at the Royal Victoria Hospital, we are now reviewing how every Trust monitors the water supply in all of their facilities.
Alan Robinson.
For Mr Speaker.
I thank the member, and I recognise that arrangements for clinical negligence indemnity are a matter of concern for GPs locally. In financial year 2023-24, £1 million of funding was reallocated from other areas of the general practice budget on a one-off, non-recurrent basis to support GPs with indemnity costs. As part of the 24-25 General Medical Services Contract, which was agreed with the Northern Ireland General Practitioners Committee in May this year, £38.9 million of funding was released for repurposing as a result of the incorporation of the Quality and Outcomes Framework and specified enhanced services into the core contract, and with the inclusion of funding for clinical waste also moving into the core. Now, of this, £5 million was allocated to GP practices on a per capita basis towards indemnity costs, and that was an interim measure pending the identification of the long-term model of indemnity. Documentation outlining the detail of the contract agreement set out how the reallocation of funds with the GMS envelope would work. Further clarification on these arrangements was issued to all GP practices on the 18th of September, but I'm aware of the issues raised by the Northern Ireland General Practitioners Committee in relation to the outworkings of the 24-25 GMS contract, including the funding for indemnity. And indeed, I met the chair of the General Practitioners Council, Dr. Francis O'Hagan, this morning and discussed those concerns and explored options for moving forward. And we will continue to engage with the committee representatives on this issue. And looking to the longer term, a number of possible indemnity options have been identified, ranging from the current model to state intervention that includes a number of state-backed model options.
Mr Robinson.
Thank you, Mr Speaker, and I thank the Minister for his answer today. Given that the BMA have highlighted and are highlighting that many GP practices have seen no real benefit to the £5 million within the 24-25 GMS package that was announced by the previous Minister, does he agree with me that it is important that a long-term model for GP indemnity is got right? Because if not, it will continue to act as a chill factor for GPs wishing to practice in Northern Ireland, or indeed remaining in Northern Ireland.
Minister.
I thank the member for his supplementary question, and I think it is a very important issue. Having spoken to Dr. O'Hagan and some of our colleagues this morning, it is clear that there is at least a misunderstanding or a misinterpretation of the current arrangements, which is causing some disquiet within general practice doctors. This needs to be resolved. It needs to be resolved at pace. But at least as importantly, because this is an interim measure that we are discussing, we need to move to a solid state, long-term solution on the question of indemnity. And I can say to the member, during the discussions, we talked about several issues which might help to resolve this. And my officials were keen to say that by the end of the calendar year, if not well before then, they hope to be in a position to sit down with Dr. O'Hagan and colleagues and present what we hope will be an acceptable long-term solution to this issue, because, as the member says, GPs feel exposed in a way they don't feel exposed in other areas of the United Kingdom, and that is clearly a problem with the sort of potential consequences the member has outlined.
Paula Bradshaw.
Thank you, Health Minister, for your answer so far. Just to drill down a bit in terms of the funding that they received, you called it per capita basis in the past. Can you confirm whether that was additional money or was that just within the current contract and it was rejigged? Thank you.
Minister.
Yeah, it is my understanding that what happened was there was a negotiation not just about the money that would go into the General Medical's contract, but also about the work that would cover. So there was a rejigging of the services that were to be commissioned within that. But my officials are clear, and it's not necessarily accepted by all, but my officials are very clear that what was going on there was money was being ring-fenced, that there was £5 million which was to be used for the indemnity of GPs. Now, I think it would be fair to say that it is pretty well known outside of this chamber that GPs are not on that same page as me. And I would tell you that what I have offered is independent arbitration, to look at the contracts and to tell us who's right and who's wrong. And if we're wrong, we are at fault. But we are confident that any independent assessment would find in our favour, as the GPs are in terms of their side.
Colin McGrath.
Thank you very much, Mr. Speaker. Minister, is it not the case, the medical fraternity is quite clear about this, they were offered money for GP indemnity, we all lobbied for that, and we were told that it was being delivered, and when it's actually got onto the ground, they did get the money, but the money was removed from other parts of their contract. This is a sleight of hand that has to be sorted out because it's impacting face-to-face delivery on the ground for people in our communities.
Minister.
Well, I have to say to the member, the use of the term sleight of hand will be deeply resented by officials in the Department of Health, and I would encourage you to eyeball them and make the accusations to them, because there was a very frank, honest and robust discussion this morning on this issue, and my officials are absolutely certain in their position, and I have seen no evidence to make me doubt that. So I encourage the member, if you want to use the language like that, eyeball the officials and put it to them and let them respond.
Alan Chambers.
Thank you. Does the Minister agree with me that primary care will have a very important role to play in helping to resolve our totally unacceptable waiting times position? As such, can the Minister give an assurance that he and his department recognise the value of the primary care elective scheme?
I thank the member, and absolutely. I mean, I have talked often about shift left for healthcare delivery, and what I mean by that is getting healthcare out of hospitals and into the community and into primary care practices. And the primary care elective service is hugely important in providing 5 key pathways: dermatology, gynae, vasectomy, minor surgery, MSK. But more important than that, it is about prevention, it is about early intervention, and it's only if we do that that we will be able to transform how we deliver healthcare. And if we don't transform, as Professor Bengoa warned us last week, by the year 2040, health will require the entire executive budget, 100%. Nothing for schools, nothing for roads, nothing for anything else. So it is an imperative that we get on with that transformation. He made clear that every country, particularly every country around Europe, is seeing the budget for healthcare rising. The challenge is to de-accelerate that increase as much as possible. And primary care and doctors GPs play a crucial role in delivering that.
Liz Kimmins.
Okay, question number 5, please.
We have a minute left of your time, Minister.
Okay. The redesign of the current serious adverse incident procedure is important. It's one of my department's priorities. We're undertaking extensive engagement with a broad range of stakeholders, and this includes the Patient Client Council engagement platform, which comprises 5 individuals with lived experience of the SAI experience. I want to give way for a follow-up, if that's possible. Ms. Gimmons.
Thank the Minister for his answer and for giving way. On the back of that, Minister, I suppose it's to understand the value of the engagement that has happened to date, and are you satisfied that that is doing what it should be doing?
Minister.
Sorry, I didn't quite catch it, but I'm determined that I I acknowledge the SAI, as currently constituted, is not fit for purpose, and I'm determined that we bring one forward that is efficient, that is fast, and that is patient-centred.
Move to topical questions. Nicole Colin McGrath.
Mr. Speaker, the consultation for the Public Health Bill closed for responses yesterday. Given the obvious and significant number of objections, can the Minister detail what weight will be placed upon the responses that are received?
Minister.
Well, I thank the member for his question, and this is, of course, a very, very important area that we are discussing. I have not yet had a brief on the number of responses there have been, so I'm not even aware of that. Never mind whether they're positive or negative. I am aware of the very strong campaign against some of the proposals. And just to re-emphasise, because we're moving from the 1967 Act, which only gave cover for a number of infectious diseases, to an all hazards protection, which includes biological, chemical, radiological, I felt it was important to put all the options on the table for a public consultation. It is not for me to decide in advance, I'm going to rule that out, I'm going to rule that out. And indeed, had I not put some of those options in, there might have been another campaign to say, why have you not put those options in? And can I just say, for those who think it is draconian, we have this 1967 Act. It already provides for a magistrate's order that a person suffering from a notifiable disease that presents a serious risk to others can be removed or detained in hospital for a specific period. And it empowers authorised officers to, quote, do all acts necessary, unquote, to give effect to that order. That's the Public Health Act 1967, Part 1, Section 3, A, 1 and 2.
Minister, if there are numerous objections to a specific part of the consultation, will you give an undertaking that if that's the will of the public, that you will remove those specific clauses from any bill in the future?
Minister.
Well, no bill has been written, and the shape of the bill, the composition of the bill, will be dictated to an extent by the public's reaction to that consultation process. But it will also be up to this Assembly and to the Committee of Health to decide the shape of the bill. So, again, I don't feel that I am the only person making decisions here. I think I shall use the consultation to try and shape the bill. You know, I'm personally not in favour of forced vaccinations, but it happens. During COVID, for example, over 50s in Italy were subjected to forced or compulsory vaccinations. I will shape the bill as I feel best, but I will bring it to this chamber and to the committee, and I will ask you, help me shape this so that we get the right balance between protecting population health and upholding human rights, personal liberties. And I have to say to the member, there was a draft equality screening, a draft disabilities duties and a draft human rights assessment published alongside the bill.
Harvey.
Minister, elderly people between the ages of 75 and 80 have been selected to receive the RSV vaccine this year. Could the Minister inform us if his department has any plans to extend this group to all patients with respiratory disease, such as cystic fibrosis, COPD, farmer's lung, to mention a few?
Minister.
Well, I thank the member for his question, and I have to say we do not have plans in that area, and the reason is we are following Great Britain in terms of the advice and the rollout of that vaccination.
Mr. Harvey.
Minister, do you think that might change?
I'm afraid not.
Morris Bradley.
Can I ask the Minister, I attended a recent listening event in the Lodge Hotel when the Northern Trust suggested an extra 30+ ambulance trips would be necessary if Causeway Emergency Department were to be moved to Antrim, plus an undefined number of private ambulances added to that figure. Bearing in mind that a bleed-out injury would not survive a trip to Antrim, has the Minister examined the cost of these extra journeys and the threat to life being ferried from Causeway to Antrim?
Minister.
Well, I thank the member, and I acknowledge that there are legitimate concerns when you move services from one place to another. And Yes, the Northern Trust are consulting on removing emergency general surgery from the Causeway and Coleraine to Antrim Area Hospital in Antrim Town. But that is a live consultation, and it is only when we've got to the end of that process that we will be drawing up, or the Trust will be presenting the Department with an outline business case. I would say a couple of things to the member. The emergency department will still stay at the Causeway, and the important thing, if somebody is in a bad way, is to stabilise them. That is the absolute priority. I am seeking assurances, and I'm getting to some extent assurances, that once that is done, it is not a life-threatening thing to do to move that patient to Antrim Area Hospital for the procedure they need of an emergency nature. I would also say to the member, it just makes sense logically, wherever possible, to separate out emergency surgery from elective or planned surgery. If you are on a list, and it doesn't matter whether you've been waiting a month, a year, 5 years, if you wake up at 6 o'clock because this is the day of your procedure, only to get a phone call or a message to say that that procedure has to be postponed because there's emergency surgery taking place in the theatre that you were supposed to go to, how deeply frustrating is that? So in terms of achieving the productivity and efficiency that I'm seeking from the Trust, it does make sense, as a matter of course, to separate emergency and elective surgery, but it has to be done in a safe way, and I will assure the member that before any final decisions are taken about moving any services from one hospital to another, that safety of patients will be the priority concern.
Mr. Bradley.
Thank you very much, Mr. Speaker, and I really thank the Minister for his detailed response. But Minister, if you take a map of Northern Ireland and you take the proposed health proposals, you will find that nearly all specialist services will be centred in and around Belfast, of which Antrim is part, and it leaves us on the north coast and right through North Antrim, right through East Londonderry, with one hospital, and that's the Altnagalvin. And that's putting lives in the Causeway Coast and Glen at risk. My own preference, having listened to all that was said at that meeting, is that option 5 should be the preferred outcome, not option 7. And I would like to know, nobody can answer, how they arrived at option 7.
Minister.
Well, I think I know how they arrived at option 7, and that was by listening to the clinicians. And I visited the Causeway and then the Antrim area one day a few weeks ago, and I met some of the clinicians who were involved. And I have to say to the member, their view was that the option was not, as the Trust put it, their preferred option. In the view of the clinicians, it was the only and the essential option, otherwise services would be closer to the danger of collapse. And I understand that for everybody, healthcare is both personal and local. And everybody would like, in an ideal world, you'd like an acute hospital at the end of every street. And we cannot do that. And we have to reconfigure how we deliver our services. And I have acknowledged in this House before, there is obviously going to be a tension between clinical opinion and community opinion. And I think one of the challenges for us is to say to people, for example, with this proposed move under option 7, as the Minister calls it, of general emergency services from Coleraine to Antrim, that that's only half the story. And that half of the story is taking something away from people who access the Causeway Hospital. But the other half of the story is we're going to put something in. We're going to make the Causeway Area Hospital an elective overnight stay centre. And that means a lot more efficiency will be delivered because elective procedures will not have to be cancelled because of emergencies. And actually, it will deliver better outcomes with a proviso that we will very carefully assess any potential patient risks by moving services from one hospital to another.
Alan McGill.
The Minister, I'm sure, will be acutely aware of the serious issues and workforce challenges within children's social work teams right across the North. Can the Minister therefore advise what action he has taken to date to address the key issues, including better pay and to reduce high staff vacancy lists?
Minister.
Well, pay and workforce challenges are amongst the most pressing and difficult and intractable issues we have. I acknowledged previously, for example, in terms of pay rates within health and social care, it is very difficult, if not impossible, to compete with Sláintecare. And so particularly on the border areas, the trusts, the Western and the Southern trusts, have particular problems because it is now so easy with the road network transport arrangements for people to base themselves here but work in Sláintecare. In terms of the workforce, we have many vacancies right across health and social care. And all I can say to the member is we're very aware of that and we do what we can. And part of the challenge, because we can't necessarily compete on price in terms of salary, is to put together a package so that it is attractive to people. And I think Carol McKillen was making the point in terms of social care in North and West Belfast the other day. People are burnt out. It's not attractive. There's no work-life balance. And if you don't have good work-life balance, you don't have a good workforce, you have problems with your workforce. So you're identifying issues we're aware of, but we don't have easy solutions to.
Mr. Gildernew.
Thank you. And as a previous social worker myself, I do understand, and you mentioned the shift left, and social workers are out there every day of the week on the left, on the cold face in that regard. Can you provide, Minister, an update on what meetings you're planning to have with trade union and representative groups in order to address the issues that you've highlighted there?
Well, meetings actually, particularly between officials and stakeholders, including the unions, are happening all the time. I am more than happy to engage when appropriate. What I want to see is a workforce where there are no vacancies and where people are as content as possible in their role because they feel they're being cherished, they're being well rewarded. I came to this role from the Economy Committee, where your colleague Conor Murphy has been talking about good jobs, and we had several debates in that committee about what is a good job. Because you might say, well, a good job is being the consultant or the surgeon, not being the hospital porter, but we need hospital porters. So a good job must embrace hospital porters, and that means that they feel they wake up in the morning looking forward to going on a shift, that they feel as if they're well rewarded for doing their work, that they're respected and honoured for doing their work. So those are the sort of principles that I want to apply, and you know, that filters down through officials in the department who are doing the kind of day-to-day engagement. But I am always more than happy to engage directly with unions and other stakeholders.
John Stewart.
I thank the Minister for recently agreeing to my request to meet with some GPs in a busy pharmacy in Carrickfergus. Can the Minister give an assurance that both he and his department are still committed to the further rollout of the MDT programme? Thank you.
Well, I thank the member. I very much enjoyed the visit with the member to Carrickfergus and around East Antrim, and I thank him for that invitation. It was useful to see firsthand the convincing case, by the way, that the Castle practice have made for an investment in their premises. I think the pharmacy is among the top 3 busiest in the whole of Northern Ireland. In terms of multidisciplinary teams, yeah, I'm fully committed to the further rollout of the MDT programme. I think in terms of any transformation that's taken place since the Bengoa report in 2016, MDTs may be the shining example of a successful initiative. So there is a bid for funding for the wider rollout of MDTs across primary care. That has been submitted by my department to the Northern Ireland Executives Transformation Fund. Now, there's question about whether that will be successful, given the fund is 47 million per annum, but across every executive department. But if it is successful, it's proposed the rollout will progress in 2 tranches during the 5-year window of the fund's existence.
Mr. Stewart.
And that's very welcome news, and I welcome that commitment. Can the Minister provide an update on where the East Antrim GP Federation sits within that proposed rollout?
And the member will recall, I'm not sure if it was the practice manager in Castle or one of the doctors who felt East Antrim had been knocked out of its place in the pecking order. But the next 3 proposed federations for MDT are North Belfast, the South West, which is Fermanagh and Omagh, and indeed East Antrim. And all are hugely deserving of the programme. And it's my firm hope, if the transformation bid is successful, we'll be able to move at pace with the East Antrim rollout. It's something the member will have heard GPs raise on more than one occasion as very important for their area.
Dr. Reagan, we've got Less than a minute for both of you.
I think, Minister, you've got 60 seconds to answer this question. Can I ask the Minister for an update on the latest financial position of his department? And good luck to you if you can get it in that 60 seconds, Minister.
Well, we received 122 million in June monitoring. That was very welcome. It's made a good contribution to the deficit. But following an additional push for savings from our arm's length bodies, the gap is now a reduced but still significant 130 to 135 million pounds. And I commend the trusts who have made unprecedented savings this year in excess of £200 million.
Thank you, Minister. And that brings to a conclusion questions to the Minister for Health. If members would take their ease, and we'll return to the previous item of business. Thank you.